Hello, welcome to Senior Rehab Project, the podcast for the community of rehab clinicians working to advance care for older adults. I'm your host, Tali and with me is Erinn Carey. This is the SRPrereqs segment. In today's episode, we will discuss the U.S. Preventive Service Task Force to prevent falls in community-dwelling adults.
Sounds very official.
It was very official. The U.S. Preventive Service Task Force is not the Avengers, although they sound like it.
Okay, now my expectations are tempered. Thank you.
What they do is they collect and review all the evidence on effectiveness of some things, and then they have a formal recommendation. Can I call it the USPSTF instead of the U.S. Preventive Services Task Force?
I mean, if you call it a task force, I'll know what you mean, and so will our listeners most likely.
I would love to say task force instead of USPSTF.
Yeah, I think that'd be more descriptive and more useful than being like USPSTF LMNOP. Like, make it easy.
Especially that I'm dyslexic and it's way too many characters.
Yeah, seriously, I'm not dyslexic and it's too many characters.
So in 2012, the task force had recommendation on prevention of falls in community-dwelling older adults, and this one it's an update. It's the update that they had in April 2018.
So it's based on a document from 2012, but it's updated evidence since then.
I wouldn't say it's based on of what they had in 2012. What they had in 2012 is definitely included in, but it's like, you know what, every now and then we need to check ourselves. 6 years is a good time to check if the recommendations still stand. It's important enough to have a task force for this because falls, as we know, is the leading cause of injury-related morbidity and mortality among older adults in the United States. In 2014, 28.7% of community-dwelling adults 65 years and older reported falling, resulting in 29 million falls. Of the 29 million falls, 37.5 needed medical treatment or restrictive activity for a day or longer.
37.5% of those falls?
Yes.
Okay, got it.
And the estimate is 33,000 deaths in 2015. Yeah, but we're only talking about the U.S., okay?
Okay.
I want to say we're specific right now on the U.S. I want to go a little bit to the evidence review. The task force reviewed evidence on the effectiveness and harms of primary care relevant interventions to prevent falls and fall-related morbidity and mortality in community older adults 65 years and older who are not known to have osteoporosis or vitamin D deficiency. So everything that I say right now is for older adults in general in the community. There are different recommendations for people who have vitamin D deficiency and osteoporosis. And actually, there's a link inside this article to go to those recommendations.
All right, cool.
And actually, how I got to do this episode and how I got this paper of recommendation is that somebody asked me to do an episode about unstable surfaces for balance training.
Cool.
And then I got to a rabbit hole, and with my ADD, I landed on this, and it's definitely not what I was asked to do. But I thought, you know what? It's a really good basic, and it's kind of interesting and open access. So the task force makes recommendation about effectiveness of specific preventative care services for patients without obvious related signs and symptoms. Okay, so it's not for people with Parkinson's, it's not for people with Alzheimer's, it's not with people with morbidities that we know promote falls.
Yeah, it's just your general healthy older adult community dwelling population.
Yes, without vitamin D deficiency and all that. Scope of review, the task force commissioned a systematic evidence review on the effectiveness and harms of primary care relevant interventions to prevent falls and fall-related morbidity and mortality in community dwelling adults 65 years or older. The studies that were conducted solely on population with specific medical diagnosis were excluded, and it bases its recommendation on the evidence of both the benefits and the harms of the service and an assessment of the balance.
Cool. Did they define what they meant by like primary care interventions?
It means that it's preventative, that the intervention was done before fall and injury.
Okay, cool. Thank you.
This is not how they define it, but this is how it's defined in general, primary care.
I thought it was like the first line of care.
Yes, but
like, I always thought preventative was different.
You're right. It is different, but in this case, that's what it means because we're talking about prevention. So,
okay, I see.
So the intervention themselves are about prevention.
Got it. Thank you.
No, thank you for asking. But two things that are really important to say, they do not consider the costs in providing the services in this assessment.
Ooh.
And they say it right from the beginning. And also one thing that they say, and I really appreciate them saying it, is the clinical consideration. Those are recommendations, but they do understand that clinicians are not only free, but it's good that clinicians make decisions that maybe are not in those recommendations.
Yeah, we have autonomy and clinical decision-making skills.
Exactly, based on the individual. For example, if we know that someone would not be compliant with exercises, although we know that exercises are the best for him, we'll go with something else.
Yeah, I can think of a couple people like that right now.
Yeah, we all have at least
half our caseload.
They do recognize that the clinical decision involves more consideration than just the evidence alone.
That's cool. That's nice of them to acknowledge that their audience is smart.
Detection of falls. So they did say that effective primary care interventions to prevent falls use various approaches to identify person at increased fall risk, but no instrument has been clearly identified as accurate and feasible for identifying older adults' increased risk fall.
Yeah, there's no one instrument, but there's like some evidence for the constellation of instruments and symptoms and self-report measures.
Yeah, they did say that a lot of places use time up and go.
Yeah, they would.
I like time up and go.
I do too. I'm not hating on Tug. It's just so easy to do. I get it.
So easy, and give me what I want to know. Because it's open access, I'm not going to go to a lot of details that I think are really interesting, and it takes you a little bit into the mindset of the task force. Benefits of early intervention.
Let's hear it.
Okay. The task force found adequate evidence that exercise interventions have a moderate benefit in preventing falls in older adults at increased risk for falls.
No shit.
Yes, I know. So surprising.
Yeah.
One change they had from the 2012 recommendation is that then physical therapy and exercise were separate in the recommendation, and now they're together.
Because that's our jam.
It's one of our jams, and saying physical therapy is a little too wide because, okay, but what do you do in physical therapy?
Right. There are a lot of different things that we could do. But I like that they are putting us with the exercise. I know like the ACSM, I think, has been trying to push toward that. I know something that Moffitt was big on, how like we are the exercise experts and we are garbage at marketing ourselves as such. But it sounds like what we're doing is working and going in the right direction.
Yeah, so that's for exercise. The task force found adequate evidence that multifactorial interventions have a small benefit in preventing falls in older adults at increased fall risk. And they found evidence that vitamin D supplements has no benefit in preventing falls in older adults.
Wow, you don't say.
Yes. So, and that's why they said it's really important that if you do have vitamin D deficient patients, please use the other recommendations, especially for that population, Because, and I see it a lot and it drives me nuts, okay? There's a lot of people with no scientific background, or they read some things in BuzzFeed and then they just make recommendations to their neighbors, to their like, oh, you know what? You should really take vitamin D. Are you a doctor? Are you like, take a blood test? You know, whenever someone has some muscle twinging, people are like, oh, you're probably low on magnesium. Like, oh, thank you. But do you base it on something?
Yeah. What's your rationale? Let's hear it. Oh, I wanted to ask, did it say what type of exercise in the first recommendation?
I will go into that later.
Okay, cool. Thanks.
Maybe I'll go into it now.
Yeah.
It's mostly strengthening and balance.
Yeah.
But actually mostly strengthening. That's especially lower body.
That's enough of my celebrating.
Get those squats in. So those were the benefits. Harms of early intervention? Not really.
No duh. I mean, I shouldn't say no duh. It's great that the evidence supports something that I already know.
They're saying based on the non-invasive nature of most interventions, the low likelihood of serious harms, and the available information from studies reporting few serious harms, the task force found adequate evidence to bound the harms of exercise and multifactorial interventions as no greater than small. They found adequate evidence that the overall harms in vitamin D supplements are small to moderate, and evidence suggests that the harms of vitamin D supplements at very high dosage may be moderate.
What are the harms? Like what could it do to you?
Overdose of vitamin D?
Yeah. Like, what are the symptoms of that, out of curiosity?
So vitamin D is not water soluble.
Oh, you're right. It's not. Okay. All right.
So you could get vitamin D toxicity.
Yeah, I see what you're saying. Okay. Thanks for reminding me of that. A, D, E, and K are not water soluble, right?
That's true.
Sweet. I remembered something.
Nausea and stuff like that.
Yeah, nausea, vomiting, weakness, frequent urination, bone pain, kidney problems, like kidney stones. Yeah, I guessed right.
We were all good.
Yeah, cool. Yeah, so vitamin D, it's riskier than exercise.
The most common exercise component was gait, balance, and functional training.
All right. I'm not surprised by that.
17 trials were recommending that, followed by resistant training, which was 13 trials, flexibility training, which was 8 trials, and endurance training, which was 5 trials.
All right. So a well-rounded program tailored to the needs of your patient seems the most appropriate.
That, but mostly don't forget the resistant training. There were a few studies about Tai Chi, few studies that included general physical activity. The most common dosage was 3 sessions a week for 12 months. The most common frequency and duration for exercise interventions in general was 3 sessions per week for 12 months. It means that for a year, you're exercising 3 times a week.
And that's just like, that was really common in the studies that showed the strongest results.
Yeah, but the duration of exercise ranged from 2 to 48 months, but that was the most common in all the research about exercise. They do refer after that to the 28 U.S. Department of Health and Human Services guidelines about the 150 minutes per week for moderate intensity or 75 minutes per week of vigorous intensity of aerobic physical activity, as well as the muscle strengthening activities twice per week.
Yep, sounds...
Yeah, remember those?
Sounds familiar. Yeah.
I'm glad they do collect information from everything in the U.S.
Yeah, good work, task force.
So that was one intervention, exercise. Multifactorial intervention includes an initial assessment of modifiable risk factors for falls and subsequent customized intervention for each patient based on the issues that were identified.
Okay. I'm interested to see where this goes.
It goes.
I mean, it makes sense, but it's just hard to study.
It's not that hard to study because a lot of places have that, all those visiting nursing services.
But everyone is different. basically. That's why it's hard to study. Like you can't really do a control group with a tailor-made exercise program.
It's hard, but it's still important to do.
Sure. Oh, yeah.
Because we can't say, we don't have recommendations because not everybody did the research exactly the same.
Yeah.
So it's hard for us. So the initial assessment could include a multidisciplinary comprehensive geriatric assessment for an assessment using combination of various components. For example, balance, gait, vision, blood pressure, medication, environment, cognition, psychological health, all of that. In the studies, usually nursing staff perform the assessment. And based on that, they recommended a dietitian or occupational therapist or a physical therapist or exercise instructors or follow-up by social services or going to an ophthalmologist.
Yeah, so the nurse was the initial point of entry into this system. They're the one that determines where they go to get the appropriate preventive care.
Yeah, or what they need.
Okay.
Yeah.
Nurses got skills.
Listen, nurses, don't get me started about nurses. Or we should do like a special episode about nurses.
How wonderful they are and how they control so much.
How they save lives.
How they save lives, legit.
Other interventions. The following single interventions lack sufficient evidence for or against their use to prevent falls in community-dwelling older adults when offered alone or not in the context of multifactorial interventions. For example, if I didn't do the assessment in the multifactorial intervention, I can't just say, you should modify your environment.
Yeah, you can't really say that.
Yeah, so those are things that we don't have evidence for or against if it's not in the context. Environmental modification, medication management, psychological interventions, and combination interventions not customized to an individual risk profile. Okay, so don't recommend someone grab bars before you check that they really need them.
Sounds like it's a good way to save money too.
Yeah, and both save money, and it's insulting to tell someone at your age you should have a grab bar.
Right.
They also have in this paper useful resources.
I like it. I love resources.
Yeah, like the recommendation for people with vitamin D deficiency and calcium deficiency, guidelines for people that do have specific problems like Parkinson's.
I like it. So like we can take this general starting point of the paper and actually go to the paper and get things that are more specific based on the population we want. That's very useful.
It is.
I'm glad the authors thought about that.
They don't have everything here, but I like that they're very clear about this is not one size fits all. This is a general thing that we checked. So I really appreciate it. For other consideration, they also said that although the evidence does not support routinely performing an in-depth multifactorial risk assessment with comprehensive risk management in all older adults, they may be reasons for providing this for certain patients. And they do go to the guidelines of the American Geriatric Society that recommended risk assessment for multi-component interventions in older adults who have had 2 falls in the past year or 1 fall in combination with gait or balance problem.
Okay, so it can help you narrow that down. Like, this is someone I should look a little bit closer at.
Exactly. Again, it's not like we're the task force and we know best. I'm like, there's also the American Geriatric Society and they're pretty good at their job.
Yep.
They also talk about the research needed and gap. I wouldn't go there, but they do say, for example, that we do need research for older adults that are 85 and older.
Yeah, the oldest old, definitely.
And to identify effective components of exercise intervention that would be useful. So I want to summarize the recommendation and evidence. Okay?
This is like the stuff that we can take and use in the clinic tomorrow.
Exactly. And also, do you remember the ABCDI recommendations and how they go?
There are so many ABCD Everything's like airway, breathing, circulation. Yeah, I know that. That's not what you're talking about.
No. I'm talking about level of recommendation. For example, A and B, you should offer and provide this service.
Okay, you should do it.
Yeah. C is offer or provide this service for selected patients depending individual circumstances.
Okay, all right. I like this.
D is discourage the use of this service. I is things that are uncertain.
Like every medication in pregnancy, let me tell you.
No, not every. So there's a whole different thing about pregnancy.
I know.
Don't let me go into farm now. It's a whole different.
It's many of them are just like, we don't know.
We don't know because you know what? We do not want to be the ones
liable.
The ones that do this experiment.
Well, and they can't get it through an IRB anyway.
Yeah. After we cleared that. Exercise interventions to prevent fall in community-dwelling adults over 60 have B-level recommendation. So there's a moderate certainty that the net benefit is moderate to substantial. Yeah, offer or provide this service.
Yeah, that's the recommendation. Offer or provide it.
Yeah. Multifactorial interventions have C-level recommendation.
Okay. Offer and provide it when appropriate.
Yes, exactly.
I listened.
I'm so happy somebody listens, at least you.
Listen, I have gotten so bad at listening since I left school. Whew.
So it's not something that should be routinely offered, but
it should be part of your arsenal.
Consider it. The task force recommends against vitamin D supplements to prevent falls in community-dwelling adults. So it's the recommendation. I don't know why it was there. Why this will prevent falls.
Well, I think that it showed some promise in like osteoporosis research.
Yeah.
Which I think it just got all lumped together. But nope, we're teasing it out. Thanks, task force.
Yeah. And they say it again, this recommendation applied to community-dwelling adults not known to have osteoporosis or vitamin D deficiency. That's all I have to say about that.
That was a cool update, Tali. Thank you for sharing that with me and all the listeners.
I'm glad. I feel like I didn't really say anything new to us.
This is ammunition for when we're talking to our patients and trying to convince them that like those people that don't like exercise that you like have to figure something out for, you can throw this at them. Don't actually throw it at them, but you can show this paper to them and be like, look, experts say you need this. It would be greatly beneficial. I know you don't like to exercise. Please try. So that I think is really helpful to us. So thank you very much for sharing that, Tali.
Thank you. Thank you for listening and being here and saying things to me back.
You're not just like talking to yourself in a corner.
Yeah. As much as I love reading about innovations and things that are new and in the frontier, it's really important to remember the basics and go back
to like look at how the basics are still being supported to this day. Like the basics were right in this case.
Also, it's important, I think, to not only say, oh, I know the basics, like every now and then read that the basics are still proven. For example, since it's Women's History Month, research of myocardial health. The symptoms of heart attack in women are a lot of time different than the one in men.
Yeah.
And it's something that they didn't think about a few years ago. And so it's good to always go back to the basics and see that the basics are still the basics.
And that information came from that nurses study, right? Like the research done on that cohort of like thousands of nurses, all women. That was cool. Maybe we should do an episode on that.
Ooh,
Back to Basics series.
We should. Well, thank you for listening to Senior Rehab Project. If you gain from this episode, consider supporting our work. You can become a patron through Patreon, a service that allows people like you to support people like us. You can give us as little as $1 a month or become a game changer for $8.99 a month, where you get an awesome Redefined Old mug and access to our monthly meetups. Just go to seniorrehabproject.com to learn more and find the show notes for this episode. Thank you very much. Talk to you soon.